here is a relatively straightforward case with a varus deformity of the femur as well as of the tibia, and this girl landed up to me with medial compartment pain. As problems go, if we do it with an external fixator, it's not a major problem. But her issue was she needed to get back to college, so we needed accuracy, we needed to do it acutely, and we needed to allow early weight bearing. So that's her walking with the patella forward and with the foot forward. You notice that there seems to be an internal rotation deformity, and this happens quite often with patients who have a varus deformity. Movements were normal. So when you measure this, as per the deformity correction principles, she has a varus in the femur and she has a varus in the tibia also. And clinically, as you noticed, there is a question of internal rotation. So we are now using a software which is kind of in development from a group of Mumbai IIT boys, where you can generate three-dimensional images. You don't need a CT scan. You can generate three-dimensional images from just 2 X-rays, and that includes an assessment of rotation, which till now was really possible only clinically. And then you can use the same thing for planning the deformity correction. This is the bunch of boys, young people who are doing that software. So it hinges on taking X-rays with certain special markers, what's known as, in the engineering terminology, as a 3D array. So those are put onto the leg, and an AP and a lateral full-length X-ray is done without moving the marker. So you get X-rays like this, and you get the shadows of the markers. This enables the software to calculate, and they have a patented sort of algorithm, which then gives you a 3D model of that without a CT scan. And this has been shown to be accurate. Now, from this, it can automatically calculate all the numbers. The important ones here are the LDFA, that is the distal femur, MPTA, that's the proximal tibia, and the LDTA, which is the ankle. In addition to that, using the software, you can simulate corrections. So here I have simulated a valgus osteotomy of the distal femur and 2 osteotomies in the tibia. Once that is done, the numbers come back to normal. This is pre-op and this is post-op. It tells you the numbers in terms of what is the distance of the osteotomy from the nearest joint. For example, here in the femur, it's 54 millimeters. In the tibia, the first osteotomy is 102 millimeters from the joint line, etc. So we take this numbers, and normally when I'm operating, all of these numbers are available on the wall in terms of where we need to do the osteotomy, how much of an angle that needs to be corrected, etc. So once I know what I need to do, and I know from this that once I correct it, at these numbers, I'm going to get a HKA which is in slight valgus, then we just carry out that plan. In our case, we did the tibia first after a fibular osteotomy, and that allows to adjust for any errors that we may have made a couple of degrees in the tibia. I can adjust for that in the femur. So all of these markings, the distance of the osteotomy from the knee, this is all obtained from the software. And there's very little thinking that needs to be done in the theater. Most of the thinking and planning that has to be done is done outside theater. So we marked the track of the nail, marked the level of the osteotomy. This is the Cora points by wires which are overlying the bone. To ensure that the software told me that there is no rotation. So to ensure that the rotation remains straight, I put in 2 wires in the proximal and distal fragment, so that at the end of the surgery, the wires continue to be parallel to each other. The nailing is a standard regular nailing using the appropriate principles to ensure that it goes into this tract. We use all the conventional methods of using a polar wire, etc. The one thing is to use a straight reamer so that I go in a straight line and it doesn't get deviated. Then do the osteotomy preceded by multiple drill holes as dictated by the software. Once the alignment is corrected, you pass in a guide wire and ream to put in an appropriate size nail. Right? There are checks at every point, which I will come to in a bit. And then I have this method of SASTA navigation. I've printed out a protractor on a OHP sheet and putting that. So this one is measuring from the joint line what is the angle of this guide wire, which is 88 degrees, which is what we wanted to confirm that we are in the appropriate angle. And then we go ahead and do again a distal femoral closing wedge osteotomy, standard technique. You can adjust that by tightening or loosening the screw. You can increase or decrease the valgus to a certain extent and then finalize the fixation. So the important thing here is the numbers are all taken from the software. 11 millimeters of a wedge, which gives us a correction of 12 degrees. This first osteotomy is 102 millimeters from the joint line. And intraoperatively, we use various methods to again check that the alignment is okay. This is an alignment rod going from the center of the head to the center of the knee. And the software said 87 degrees, and we've got 86.9. The MPTA was 87, we've got 86.1. LDTA, it said 92, we've got 93. 1 degree is even possibly an error of measurement. So that's her post-operative X-ray, post-operative clinical. And then what we did was, on her post-op limb, we've put the same markers and done that 3D X-ray again and allowed the software to calculate the angles again. So notice the LDFA pre-op, in the simulation, it was 87. Actually, we got 87. The MPTA was in the simulation 87. Actually, in the post-op X-ray, we've got 86. LDTA was 92. We've got 91. The HKA, that is the hip, knee, ankle angle, we should have got 176. We've got 179. Right? So in terms of planning accuracy and carrying out that accuracy, the software gives us a good amount of detail to carry out even complicated sort of multiple corrections at the same time well. So we were able to get perfect planning, extremely helpful for execution because we just followed the numbers that we got from the software, and you can analyze whatever you have done in the post-operative period to achieve our goal of deformity correction. So that's our pre-op clinical picture and X-ray, post-op clinical picture and X-ray. That's her 2 months post-op, walking, 2 months post-op. So she was back to college in 3 weeks using elbow crutches, and using a nail she was able to weight bear. And that's her final picture showing that everything is healed off without any trouble. So technology definitely is going to make it easier for us to plan and carry out treatment. Thank you.